Well, good afternoon, everyone. This is Mike Hill with Total Control Health Plans, and I appreciate you joining us for our webinar today. We're trying to get this done by 12:30, and we've got a lot of content to dive into, so I'm going to jump right in, but I do invite you to submit questions via the Q&A, and I will take a peek at that as I jump between slides, and then if we have some time at the end, we can jump into that as well. So appreciate you being here. I'm going to start sharing my screen and take you through our presentation today. So welcome everyone to the Anatomy of a Self-Funded Health Plan. This is part 2 of a 5-part series. Today we're going to be talking about provider access. And for those of you that did not make our presentation a month ago, we equated a well-managed health plan to the board game we used to play as kids called Operation. And we looked at different operation boards where we didn't have any bones or organs to play with. So there was a very easy game, no bones or organs to play with, but it was hard to win because there was nothing to play with. And then we looked at another game board that had few moving pieces, and then finally the operation board that we're all accustomed to. And that's what we're looking at here today, that when we want to manage a health plan well, the more game pieces that we can play with, the better effect that we're going to have. And so today we're talking about provider access. And from our perspective, it's the most important organ, and we'll talk a little bit about that in just a moment. Then we're going to define what it means to have access to providers. We'll talk about the different models that we have to have access to providers, and then finally some closing key points. So keeping it moving, the most important organ. So when we're playing our game board of operation, managing our health plan as well as we possibly can, the heart is provider access from our perspective. And we've got it labeled here network because that's commonly how we do things today. And I want to just talk a little bit about why it's such an important piece. If we take a look at the Journal of American Medical Association, they said there's 6 functions for health insurance. And they are financial protection from catastrophic events, broad access for a small fee, negotiating the price of health services, enhancing and ensuring the quality of both clinicians and hospitals, and then nudging individuals to stay healthy, and a wealth transfer. And the wealth transfer is referring to the ability for employees to pay for their health insurance on a pre-tax basis. That benefits the high-income earners more than it does low-income earners. And then when we talk about the rating, that we ask low-income individuals to pay less and older individuals to pay more, we're transferring some wealth from the older individuals to the younger ones by subsidizing their cost. But when we look at the first 4 reasons or functions of a health insurance plan, they all deal with interacting with healthcare providers. And so if we have a health plan that does not make it easy for us to interact with healthcare providers, we're missing a huge component or a huge reason for the existence of a health insurance plan. And that's why we believe access to providers is the most important organ that we can play with in our game board of operation when we're managing a health plan. So let's define access. This is our perspective, but it's when we look at benchmarking information, it supports our perspective. And the reality is, all of you that are on the call today have the ability to manage a health plan, and you've got plan participants that view the world a particular way. And in 2024, it is not unrealistic for plan participants, our health insurance consumers, to believe that they're able to see any healthcare provider they want at any time, and assuming they can get an appointment with that provider, and that their health insurance is going to pay for it. There were days back in the days of yore where we were limited on who we could see, and we needed referrals to be able to do that. Most health insurance plans today let us see anybody we want and whenever we want, and our health insurance plan is going to pay for it. So knowing that's the mindset of your plan participants, we got to make sure that we're meeting them where they are, but also helping lead them to the future of health plans as we see it. So let's talk about the different types of access that we have with health plans. First and foremost, the network. Probably the vast majority of you on our call today are familiar with the network. You have health plans that use them. It is by far the most common method health insurance uses to provide access to providers. Healthcare.gov defines the network as the facilities, providers, and suppliers your health insurance or plan is contracted with to provide access to those services. So the question then is, okay, if we're all using networks, is there really a difference between them? As a child of the 80s, I remember saying, what's the diff? And so let's just talk a little bit about that. What we're showing you here is different disruption analysis that we've done with different networks, comparing them to others. So here in the upper left-hand corner, Priority Health is comparing their network for one of our clients to the network that that client is using today. And Priority Health has 99.4% overlap, meaning of the providers that are being used in one network, they've got 99.4% of them in theirs as well. PHCS, on the other hand, that's a network that's a rental network not tied to any insurance carrier. It's a national network, but in Michigan anyway, it's a little bit more limited. They have less access to providers than others might. But when we did a disruption analysis comparing one network to PHCS, there was still 80% overlap, meaning 80% of the doctors that were in a very prominent network are also in PHCS. And then at the bottom here is taking a look at the Aetna network, a national network owned by the health insurance carrier Aetna, comparing their network to another national big prominent network, and they had almost 99% overlap. So what's the point here? Well, when we're talking about networks, in terms of being able to access providers from one network to another, they're almost all the same today. Networks don't want to be limited and have to compete, with their one arm tied behind their back, where one large health system is in one network and not in theirs. So there's almost complete overlap from network to network. It's really not a big deal to change from one network to another if it makes sense. So then why would we choose one network over another? Well, networks help us obtain procedures and services at a discounted rate. Ultimately, networks are competing not necessarily in access, but what we might pay in claims when the certain claims run through their network versus another. And we'll take a look at in just a moment how they differ from one another. But what are the advantages of using a network? First and foremost, the concept is familiar to most plan participants. We've been doing this for quite some time now. While a little bit clunky, people are still fairly familiar with what a network is. Generally speaking, they're relatively easy to navigate. Some networks have better provider directories than others, but generally we can make our way through a network arrangement. And while not flawless by any stretch of the imagination, the network concept is the least bumpy from a member experience standpoint. So if we're trying to build an easy to use health plan, the network's where it's at. But what are the downsides? Well, the pricing is based on a flawed model, and there's certainly multiple different pricing models a network might use, but generally speaking, it's a percentage discount off of whatever the hospital charges. And we have no control over what the hospital or medical provider charges, and we have no idea what the discount is going to be. That translates into the pricing being incredibly opaque for all of us. It's also incredibly bureaucratic and inefficient, and we'll take a look at what this looks like in just a moment, and it will, I think, maybe open your eyes to see how bureaucratic and inefficient the model can really be. And then some networks come with handcuffs. For example, if we want to use a big national network that claims they have big discounts, well, we're not allowed to audit the claims before we pay them. If a healthcare provider that's in that network submits a claim, we just got to pay it, whether it's valid or not. Also, we know that not all healthcare providers are created equal. And so we want to be able to direct employees and plan participants to the highest quality providers that are out there. But we can't do that with many of the networks. We're limited on our ability to steer within them. Basically, people can go see whoever they want, whenever they want, and we can't provide any steerage to the higher quality providers. So those are some of the downsides of the networks. And now let's dive into some specifics on the discount concept to see what that means. So many of you are likely aware of the transparency law that was passed a couple years ago, requiring hospitals to post on their website the discounted negotiated rate that they have with every insurance provider and or network they deal with. And so some hospitals have made this pretty easy to find, others have not, and some still aren't in compliance. And if they are in compliance, some make it easy and others don't. Our friends at Beaumont Hospital on the east side of Michigan make it pretty easy. They put the information on their website in Excel so the average Joe can go and look at it. So what I did is I just pulled the top 200 most common procedure codes that a claim might be billed under with Medicare, and looked to see in 4 different Beaumont hospitals if their information was on their in their Excel files. And so I just randomly picked some. So these are the same code at 4 different Beaumont hospitals. and the charge is $809. And one of the things that is a challenge about trying to make heads or tails out of the discounts and what we're going to pay is the data that's out there is still not perfect. So one Beaumont hospital consistently had the information inverted. So first is what the price is, and second is what the self-pay. And in the case of this particular hospital, it seems that they swap it in many of their columns, but we wanted to keep it the same as much as we possibly could. So what we did then is took a look at, okay, here's one Beaumont hospital. Let's shade in red the highest price that we might pay for that service and look at what network it is, and shade in green the lowest price we might pay and take a look at what network that is. So at this particular Beaumont hospital, if I have the Aetna HMO network, I'm going to pay the most. And if I've got the Priority Health HMO network, I'm going to pay the least. But in another Beaumont hospital, same price, same cash price, Aetna is still the most expensive, but now United Healthcare's HMO network is the most competitive. But then we go to a different Beaumont hospital, and guess what? Now all of a sudden, Aetna, who is worst in show at 2 hospitals, is best in show at this one. And Priority Health, big statewide player, both their PPO and HMO networks are the worst. As we continue through that exercise, what you're going to notice is there is absolutely no rhyme or reason between which networks are the best consistently and which ones are the worst in terms of what we're going to pay. And so when we talk about the opacity of the network concept or the discount issue, what we can see is that there is no way of knowing if we pick a particular network, if we're going to win all the time, if we're going to lose all the time, or if we're going to win more in general than lose. And the challenge is if you tell me which hospital your patient's going to and what procedure they're going to have done, I can tell you which network's the best one to use. And the reality is that is not a sustainable or efficient model. And that's one of the biggest issues that we have with the network concept. All right, moving back. So if it's not the network, then what are we going to do? What's our alternative? Direct contracting. So let's say we're tired of the network concept and we want to try something different. Well, the next option we have is direct contracting. And this is a growing trend in our industry, and it's driven from 2 different angles. Healthcare providers are open to the concept of direct contracting because it's far more efficient for them. And also healthcare payers like employers are also very attracted to the idea for a number of different reasons. From a provider perspective, the reason that they may want to consider direct contracting with employers and cutting the middleman out is that they can then work with that employer to design incentives to steer those plan participants to that particular provider, generating more business over time for that provider. From an employer perspective, we get a lot more transparency and control and theoretically lower costs because we're going to negotiate that, hey, if we steer our folks your way, we're going to do so, but we want a deal for it. We want you to give us a better deal than we might get through a network that we had been using previously. So then let's talk about some examples of that. So here's just some clips from Michigan news that we've seen over the last couple of years. As recently as January this year, MSU Health had partnered with a group called Nomi Health. That's a direct contracting aggregator for employers. So we could bolt the Nomi network onto our particular plan and have some direct contracts with various providers throughout the country. And MSU Health is jumping on board. But as long ago as 2018, Henry Ford Health System did a direct contract with General Motors. And in 2019, Metro and Mercy and West Michigan started direct contracting with employers. So this is not a new concept, and it's going to continue to grow from our perspective. It can actually take a couple other forms as well. If you're not direct contracting specifically with the health provider themselves, what are other ways that an employer can do that? Well, there are pre-built networks. So Edison Healthcare was actually started by the gentleman that used to run the Walmart health plan for the employee benefit program at Walmart. And they established a Centers of Excellence network of providers around the country that specialized in musculoskeletal type services, for example. And they now have that network that's available to employers where that can be bolted onto an existing plan. The Surgery Center of Oklahoma has been publishing prices online since 2009, and you can direct contract with them and steer your employees there, knowing exactly what you're going to pay prior to the employee walking into the door to have their services rendered. In addition, there's a growing concept of direct primary care, where primary care providers are basically creating a subscription-based model where members then can see the provider as often as they want for as long as they want for one flat fee on a monthly basis. Now, the challenge with direct primary care providers is that if you've seen one direct primary care provider, you've seen one. And if you've got employees spread out across a broad geographic area, that's going to be a challenging solution to apply to everybody potentially. That's where Hint Health comes in, creating a network of direct primary care providers that employers then can tap into and provide that service to employees nationwide. Coral is a platform that's taking direct contracts that people such as myself and others are out negotiating with providers around the country and putting it into this clearinghouse that then employers can access across the country for various services if they want to do that. So direct contracting is growing at a high rate of speed. It can take many forms, and there's a lot of advantages to it, but it's not flawless. So let's talk about that. Direct contracting provides transparency in pricing in many cases. When we interact with the healthcare providers, we know what we're going to pay them up front, and we can actually then also include some performance-based components to it, like bundled pricing. Meaning if you provide a particular service to my patient and they have to come back for warranty work, let's say, we're not going to pay you anymore. It's all part of the initial price we paid you. We're eliminating the middleman, so there's way more transparency and simplicity for everybody involved. And there's flexibility. You, the employer that's building and managing your plan, can decide who it is you want to enter into these agreements with or not. What are the downsides, though? Well, if we're doing direct contracting and trying to select a handful of providers that we can work with to get more transparency and better pricing, we're likely going to have a more limited panel of providers. And if we think back to what your employees and plan participants think today, they can see any provider they want whenever they want. And if we're using direct contracting, we might start limiting who they can see. In addition, if we're partnering with a particular health system, as I showed earlier, a couple slides prior, Metro Hospital, which is now University of Michigan West, or Mercy, which is in West Michigan, they're not going to just partner with us and contract part of their services. They're going to want to partner their entire health system with us. And we know that not all healthcare providers within a system are created equally. And so if we do that and partner with a particular health system, we got to take the good with the bad, or the wheat with the chaff. And we're going to change the member experience because, again, they're expecting they can go wherever they want, whenever they want today, and we're going to tell them no. And frankly, then if we're going to be doing this, it's going to take more work to set these things up and to educate people and to continue to manage them. So a lot of upside, but it's certainly not a no-brainer. Okay, well, what about direct contracting? If that's not for us, then what's next? How about reference-based pricing, or RBP as we put it? So reference-based pricing is an alternative to the network model that puts the plan sponsor, the employer, in the driver's seat. And what we're doing in this particular case is using Medicare as a reference point for determining what the plan's going to pay. So rather than the healthcare provider saying what they're going to charge and us getting some unknown discount off of it through the network that we've chosen, we're going to tell them what we're willing to pay based upon the Medicare fee schedule, resulting likely in lower costs and more control. But it's not flawless either. Let's talk about the pros and cons. So the pros is price is clear. We know exactly what it's going to be. We're paying a multiple of Medicare, and we know what Medicare would pay. Generally, in a reference-based pricing model, the price is lower than what we're going to get through a network, and the price is consistent. We're going to say every hospital for this, or it doesn't matter who we're seeing for this particular procedure or however it's going to be, we're reimbursing X% of Medicare. Downside is, though, there's no consensus on what reimbursement level is appropriate. What's fair? We may have a sense that, hey, we want to pay as little as possible, but the healthcare providers are certainly going to disagree with us. And depending upon where we set that reimbursement level, we may be getting some balanced bills, or your plan participants may be getting balanced bills. For example, we say the hospital wants to charge $500, but Medicare says, you know what, we're going to pay $100 for this particular procedure. We decide we're going to pay 1.5 times Medicare, or $150. Well, that doctor still thinks they want $500. And so someone's got to pay that difference. And they may come to your participants and say, listen, your plan only paid $150. We feel we're entitled to $500. You owe us the difference. And that's scary for plan participants, and it's not ideal because we might end up paying more. If we agree to pay that difference, we're ultimately going to pay more than we would through a network. And we have to have a lot more member engagement because this feels a lot different, both in front of the plan participants and in front of the providers, than the network model works today. So let's take a little bit of a look at what the impact of reference-based pricing is on a plan from a financial standpoint, from a balanced bill standpoint, and then find out, you know what, is this really something that's worthwhile for us to pursue? This is a report from a client of ours that uses that model throughout West Michigan and throughout the country. And what this is taking a look at is the top healthcare providers this particular client has been, their patients have been seeing. Ultimately, what we want to see here is what do we end up paying? And in the lower right-hand corner of this chart, we're seeing that we're paying almost 1.4 times what Medicare would pay. When we also look at the top providers by how much was billed, or this, excuse me, this top is how much was billed and this is how much was spent. Again, we're achieving about 1.4 times what Medicare would pay. Is that good or is that bad? Well, we'll talk about that in just a moment. But as I mentioned, one of the downsides is when we use this model, there's nothing obligating these healthcare providers to take what we pay as payment in full. And so when they want to charge us more, then we ultimately are going to have to figure out how we're going to handle that. And in this particular case, for a 12-month period of time, this particular employer had 12 balance bills where the provider came back and said, listen, we need more. And we can see the various hospitals that it was and how many times we got balance billed. And then ultimately, what of the percentage of claims that we paid there, what percentage were accepted at what we decided to reimburse versus how much got balance billed. And then how did we deal with that? Well, a significant percentage of the time, 70% of the time, we had to go back and pay them more than we originally wanted to. There are other cases that we might have to negotiate some more and help them understand that they're seeing the world differently from us and why our way is the right way. But it gets a little bit messy from the employee perspective and also from the plan perspective. So the question is, again, if we're achieving 1.4% of Medicare, 1.4 times Medicare, is that good? Well, let's take a look at something here real quickly. So the RAND organization put together some great reporting, taking a look at what hospitals are ultimately charging across the country and what that is in relation to, or actually what health plans are paying healthcare providers and as a percentage of Medicare, and if that is ultimately good or not. And so what I did is I took a look at all Michigan hospitals, kind of the big names, and I filtered this out from some of the smaller independents, but took a look at what we're paying on average for Medicare for outpatient, for inpatient, and then a blend. And we can see what each hospital ultimately is getting paid through self-funded medical plans over time. And for outpatient, the average is 1.7 times or 170% of Medicare. For inpatient, it's 1.5 times, and the blend's 1.6. So when we compare that to the average that we're achieving through a reference-based pricing plan at maybe 1.4, the question is that difference enough, that savings enough to justify all the potential downsides that we might encounter? Ultimately, that's for an employer to decide. And it's not always a no-brainer by any means. All right, moving right along. We've got a lot to cover here, and we're going to wrap this up, and there certainly will be a lot more to talk about in subsequent conversations. Okay, so we talked about networks. We talked about direct contracting. We talked about reference-based pricing, and they all have their pros and cons. So maybe there's a way to kind of get the best of all. And that's what we're calling the hybrid approach. And as reference-based pricing, direct contracting, direct primary care, narrow networks, and all of the above become more and more mature, more and more employers and plan administrators are looking for ways to bundle all of those concepts into one strategy to achieve the best possible outcome and minimize the disruption to members. The reality at the moment, though, is this is a very fluid process and constantly evolving. And depending on who it is you're talking to, their definition of a hybrid approach is going to be different. And so this is certainly one that we need to stay tuned for News at 11 because it's going to continue to change over time. What are the pros? Well, many of the cons of the different models we described can be minimized, but it also is not a flawless model either. The end result can be very clunky. If we're having direct contracts and we're using direct primary care and we're using reference-based pricing in instances, it's really going to be confusing for plan participants on what's happening at any given time and who's on first. And that's going to be true for plan administrators too. We're not going to solve all the problems and things are going to fall through the cracks. And we're going to need the employees and plan participants to have a massive mind shift because today they're accustomed to being able to see whoever they want, whenever they want, and assuming their plan's going to pay it. And we may be changing that reality for them. So in closing, let's talk about some key points and some things that we want you guys to think about. And then we'll circle back to see if we have any questions in the 5 minutes that we have remaining. A couple key points. This is my prediction, and I believe it's going to be true, that in the next 10 years, the network as we know it with healthcare plans is going to go away. As we talked about at the outset of this conversation, The vast majority of networks have the vast majority of providers. And so from an access standpoint, they're all relatively equal to one another. A few years ago, the government passed a law that puts this information out there and available for us to consume. And technology is being developed to make that stuff easy to access. And as we can start to see who's got what from a network perspective, we're going to start to see who's got the best and who's got the worst. And the reality is there is no consistent answer across the board. So we're going to start asking ourselves, why are we using this network model and taking the downsides that go with it, the handcuffs that we have to deal with, and the lack of transparency. So because of those things, we think that there's going to be continued growing agreement from all sides that that model is outdated and we need to do better. And frankly, the networks create such an administrative burden for all players involved that it's just incredibly inefficient, and savings can be realized if we get rid of it. I felt this was a really worthwhile chart to share with you guys. If we take a look at the brown down here at the bottom, this is the growth in physicians in the healthcare world from 1970 to 2009. The yellow reflects the growth in administrators related to healthcare in that same time period. And buried in this yellow are a lot of people who all day, every day are trying to figure out, did they get paid the right amount from that network for that particular provider? And no one really knows. And so this is not a sustainable model. And so as we look to try to fix this, networks, I think, are going to go away as part of that process. Additionally, here's one thing that we believe that employers are really going to need to think about and evaluate how we improve your health plan in terms of providing access to providers, specifically primary care providers in the coming years. So the American Medical Association just a few days ago announced another study that they had looked at, or they put together, that we are going to be short 86,000 medical providers by 2036. As folks get older, which more and more folks are doing, we consume more and more healthcare. So we need more and more healthcare providers, and ultimately we're getting less entering the profession. And so it's going to be harder and harder for people to get in to see doctors. It's not that their plan won't pay for it. It's just there's not enough doctors to go around. And so there's a lot of different ways to skin this cat. As I mentioned, direct primary care is one way to do it. And there's a number of other ways to provide access for your plan participants to primary care providers in a very short amount of time. Yes, it comes at a cost, but we believe it's going to provide a very significant competitive advantage for the employers that have a solution to provide access to primary care providers to their employees in almost real time. So more to come on this, but as we talk about how your health plan can evolve, this is one thing that you'll need to keep an eye on. And if you can start partnering with healthcare providers to ensure access to them, it will provide you a competitive advantage. Finally, last but not least, the closing points here. Providing access to healthcare providers in ways other than the traditional network, it's hard to do. Direct contracting is not easy, and it's not an end-all be-all. Reference-based pricing is hard and can be messy, and using a hybrid approach is also hard and messy. So it's hard, and it creates noise because it's different than what your plan participants are accustomed to. And it can be frightening from an employer perspective and certainly from a plan participant perspective. And also, as I mentioned, it's a moving target. These things are evolving at a high rate of speed. The one thing that we do know, though, is that considering how we're going to go about doing this is a must. It's going to continue to evolve, and we need to rethink how we're providing access to providers with our healthcare plans, if not just for the financial reasons, but also because it's continuing to be, we're going to be forced to do so because we're going to lose access to providers simply because there's not enough of them to go around. So how do we get ahead of the curve on that to make sure that plan participants have the ability to see the providers they need when they need to see them? This is a topic that we could spend an hour and a half on, but we're committed to keeping this up to 30 minutes or less. So we appreciate you all taking the time. We have a couple moments left here to answer any questions. Are there any questions that may want to pop up in the Q&A section? Not seeing anything at this time, so we really appreciate you taking the time to be with us today. As I mentioned at the outset of this on our first slide, that there is SHRM credit for this, and we can get the code out to you if necessary if you'd like to get the hour credit for joining us today. So thank you so much. We look forward to seeing you the last Wednesday of next month of April to hit on topic number 3 of our 5-part series. Thanks so much for being with us today.